Hepatitis B is an infectious disease of the liver caused by the hepatitis B virus. Hepatitis B is an enveloped DNA virus of the family Hepatinovirus. It consists of a core antigen surrounded by a surface antigen. The hepatitis B virus has 8 distinct genotypes, A to H, which vary in geographical distribution. The different genotypes cause diseases that differ in severity and respond differently to treatment. Chronic hepatitis B is not a notifiable disease. However, laboratories have a statutory requirement to report all diagnoses of hepatitis B, both chronic and acute, to health protection teams at PHE. It occurs when there is failure of the immune system to clear the virus, causing persistence of hepatitis B surface antigen in the circulation for more than 6 months. Chronic infection occurs for reasons that are not fully understood, but are in part determined by the genotype of the infecting HBV strain and the host immune response. Hepatitis B virus-infected hepatocytes become inflamed and necrotic, not as a direct result of infection, but via the host cellular immune response. The resultant liver damage may eventually lead to cirrhosis and hepatocellular cancer. The risk of developing chronic hepatitis B infection depends on the age at which infection is acquired. The risk is lowest in adults and greater than 90% in neonates whose mothers are HBe positive. Chronic infection is less frequent in those infected as children. The risk of becoming chronically infected with hepatitis B is increased in those whose immunity is impaired. Approximately 25% of adults who become chronically infected during childhood later die from HBV-related liver cancer or cirrhosis. The risk of progression is related to the level of active viral replication in the liver. People with chronic hepatitis B infection, particularly those with an active inflammation and/or cirrhosis, where there is rapid cell turnover, are at increased risk of developing hepatocellular carcinoma, HCC. Chronic hepatitis B infection usually has a benign course in healthy non-drinkers with normal liver function. Chronic hepatitis B can be divided into E antigen positive or E antigen negative disease, based on the presence or absence of E antigen. The presence of HB antigen is associated with higher rates of viral replication and therefore increased infectivity. In the UK, the majority, 95%, of chronic hepatitis B infections occur in migrant populations, having been acquired perinatally in the country of birth. Where new infections are acquired in adulthood, the source of infection is most commonly via sexual contact or sharing of drug-injecting equipment. Transmission by blood-to-blood contact. Sharing of drug-injecting equipment use of injected drugs is the biggest risk factor for new infection in the UK. The virus can persist outside the body indefinitely. Occupational hazards. These include needle stick injuries or direct exposure of mucous membranes or breaks in the skin, including the eyes or, rarely, following bites, to infected blood, blood transfusions, and blood products. The risk of contracting hepatitis B from blood products in the UK has been virtually eliminated. People who receive blood transfusions from some other countries may continue to be at risk. Tattoos, body piercing, or acupuncture. There is a risk of transmission if equipment is not sterile. People carrying out these procedures are also considered to potentially be at risk. Household contact and sharing of toiletry items. Hepatitis B is not spread through food or water, sharing eating utensils, hugging, kissing, hand-holding, coughing, or sneezing. Occasionally, infection may be transmitted via a household or casual contact, including by direct contact between young children in the home or at childcare facilities. There is a risk from sharing items such as toothbrushes and razors. In hyperendemic areas, chronically infected children can inadvertently contaminate environmental surfaces with cuts or open sores, leading to horizontal transmission. Sexual transmission. Transmission occurs via mucous membranes, vaginal, anal, and oral, during sex. People having unprotected sex, vaginal, anal, or oral, or having multiple partners are at greatest risk. Mother-to-baby transmission, perinatal transmission, during childbirth, is common in areas of high prevalence. However, mother-to-baby transmission has been reduced by the universal vaccination program recommended by the World Health Organization. Transmission to the unborn fetus is relatively uncommon, accounting for less than 5% of mother-to-baby transmissions. Hepatitis B cannot be transmitted to infants during breastfeeding unless nipples are cracked or bleeding. The risk of developing chronic hepatitis B infection depends on the age at which infection is acquired. The risk is lowest in adults and greater than 90% in neonates whose mothers are HB positive. The virus is transmitted by parenteral route via infected blood or body fluids. People at high risk of hepatitis B include injecting drug users and their close contacts, people who change sexual partners frequently, particularly if they are men who have sex with men, travelers to areas with a high prevalence, usually via sexual exposure, largely heterosexual, or invasive medical procedures, people from a country with a high prevalence, due to high risk of perinatal transmission subsequent acquisition in endemic areas, sex workers and their clients, household contacts of people with hepatitis B, a case or a carrier, including close family and carers, families adopting a child from a country with a high prevalence of hepatitis B, people receiving regular blood or blood products, such as people with hemophilia and their carers, people with chronic renal failure or chronic liver disease, people with an occupational risk, such as healthcare workers, laboratory staff, and morticians, looked after children and young people, including those living in care homes, prison inmates, and staff, infants born to women with hepatitis B infection, Hajj and Umrah pilgrims who have had their head shaved, risk when using unlicensed barbers. Acute hepatitis B virus, HBV, infection. Symptoms and jaundice generally last for 1-3 months. Fatigue may persist beyond resolution of abnormal liver function tests. Hepatitis B surface antigen is cleared in 95% of immunocompetent adults. In more than 90% of people, lifelong immunity is achieved after clearing the infection. Fulminant hepatitis is a rare complication of acute hepatitis B infection, affects less than 1% of people. If present, however, it can progress rapidly to life-threatening liver failure with coagulopathy, encephalopathy, and cerebral edema. The mortality of acute hepatitis B is less than 1%. Chronic HBV infection, persistence of hepatitis B surface antigen in the circulation for more than 6 months, occurs in up to 15% of infants born to hepatitis B, positive mothers, if they are not immunized from birth, between 10% and 20% of children infected in later childhood, approximately 4% of healthy adults who acquire hepatitis B infection. However, rates of chronicity are higher in adults who are immunocompromised, have HIV infection, or chronic renal failure. There is a risk of extrahepatic manifestations such as glomerulonephritis, vasculitis, and polyarteritis with both acute and chronic infection. It is possible to have chronic HBV infection, but not chronic hepatitis. Liver inflammation and fibrosis in chronic HBV is caused by the immune response. List of complications is as follows: fulminant hepatic failure, relapse, prolonged cholestasis, chronic hepatitis, cirrhosis. Patients with decompensated cirrhosis should be treated in specialized liver units, as treatment with antiviral therapy is complex, and these patients may need liver transplantation. HCC, there is high risk of this in some non-cirrhotic patients, including African patients over the age of 20, Asian males over the age of 40, Asian females over the age of 50, and patients with a family history of HCC. Glomerulonephritis, cryoglobulinemia. Concurrent hepatitis C infection can lead to fulminant hepatitis, more aggressive chronic hepatitis, and increased risk of liver cancer. Concurrent HIV infection increases the risk of progression to cirrhosis. Chronic infection involves 5 distinct phases, with different prognoses. Each phase depends on the interplay between HBV replication and the person's immune response. Phases are characterized by factors including the presence or absence of serum antibodies and antigens, particularly to hepatitis B antigen, HBB DNA levels, and alanine aminotransferase, ALT values, as a marker of liver necroinflammation as follows. Phase 1. Hepatitis B antigen positive chronic HBV infection, also known as the immune tolerant phase, suggested by a positive serum hepatitis B antigen. High levels of HBV DNA and normal ALT usually occurs during the initial 15 to 30 years of infection. The person is likely to be very infectious. No treatment is generally required. However, 1.7% to 4.5% of children and adolescents infected at birth have cirrhosis at liver biopsy, and hepatocellular carcinoma, HEC, can occur. Phase 2. Hepatitis B antigen positive chronic HBV infection, also known as the immune clearance phase, suggested by a positive serum hepatitis B antigen, high levels of HBV DNA, and elevated ALT. May occur after several years of the first phase, but may be more common or reached more quickly in people infected during adulthood. Progressive liver fibrosis and significant necroinflammation are often observed. During this phase, some people spontaneously seroconvert from hepatitis B antigen positive to negative and develop antibodies to E antigen. Phase 3. Hepatitis B antigen negative chronic HBV infection, also known as the inactive carrier phase, suggested by serum antibodies to E antigen, anti-HB. Undetectable or low HBV DNA levels and normal ALT. People remaining in this phase have low risk of progression to cirrhosis or HEC. Phase 4. Hepatitis B antigen negative chronic hepatitis B, also known as the immune escape phase, represents reactivation of the hepatitis B virus, suggested by lack of serum HB, usually with detectable anti-HB, and persistent or fluctuating moderate to high levels of HBV DNA, as well as fluctuating or persistently elevated ALT. People in this phase exhibit liver inflammation and progressive fibrosis, are at high risk of progression to cirrhosis, liver failure, and hepatocellular carcinoma, and rarely experience spontaneous disease remission. Phase 5. HB surface antigen negative phase, also known as occult HBV infection, characterized by serum-negative HB-Sag and positive antibodies to HBC, anti-HBC, with or without detectable antibodies to HB surface antigen, anti-HBS. People in this phase have normal ALT values and HBV DNA is usually undetectable. If HB-Sag was lost before the onset of cirrhosis, this phase is associated with a minimal risk of cirrhosis, decompensation and HCC, and improved survival. However, if cirrhosis developed before HB surface antigen loss, the risk of HCC remains. Prognosis. Without antiviral treatment, the 5-year cumulative incidence of cirrhosis in adults with chronic hepatitis B is 8% to 20%. People with cirrhosis are at significant risk of decompensated liver disease if they remain untreated. 5-year survival rates among people with untreated decompensated cirrhosis can be as low as 15%. Alcohol consumption or co-infection with hepatitis C, hepatitis D, or HIV can lead to faster progression of liver damage and increase the risk of cirrhosis and hepatocellular cancer. There is a 2-5% annual risk of developing HCC in people who progress to cirrhosis, and this is detected an average of 30 years after initial infection. Cancer is more likely to develop when there is active liver inflammation, virus replication, and rapid cell turnover. The prognosis is poor unless it is diagnosed very early. Note: while cirrhosis appears to be the most significant risk factor for HCC, percent to 50% of HBV-related HCC occurs in the absence of cirrhosis. Diagnosis. Consider hepatitis B serology in the following groups: people who are asymptomatic who are at high risk of hepatitis B infection. In particular, screen opportunistically those who are more likely to have been exposed to hepatitis B, such as immigrants from areas with a high prevalence, injecting drug users, and sex workers, have been sexually assaulted, have sustained a needle stick injury, are HIV positive. People with clinical features that could be indicative of hepatitis B for acute infection. These include a prodromal illness that includes fever, arthralgia, or a rash. that may appear about 2 weeks before the onset of jaundice, then resolves in acute hepatitis B. Nonspecific malaise, fatigue, fever, nausea, and poor appetite. Right upper quadrant abdominal pain. Jaundice, with dark urine and/or pale stools of cholestasis. Extrahepatic manifestations such as glomerulonephritis, vasculitis, and polyarteritis. Note, acute hepatitis B infection is asymptomatic in almost all infants and children, 10–50% of adults, and is especially likely in people with HIV. For chronic infection, there are often no physical signs. After many years of infection, depending on the severity and duration, there may be signs of chronic liver disease, including spider naivety, finger clubbing, jaundice, hepatosplenomegaly. In severe cases, thin skin, bruising, ascites, liver flap, and encephalopathy. People with abnormal liver function tests. In acute hepatitis B, alanine aminotransferase, ALT, and aspartate aminotransferase, AST levels may be significantly increased, usually between 500 and 10,000. Bilirubin may be elevated, usually between 85.5 and 171, but can reach up to 500. Alkaline phosphatase is generally less than 2 times the upper limit of normal, but higher if there is cholestasis. Prothrombin time may be prolonged. 5 seconds or more suggests severe hepatitis, and 50 seconds or more suggests acute liver failure. In chronic hepatitis B, in most people, the only abnormality will be mildly elevated serum aminotransferase levels. In many, liver enzymes will be normal. Diagnosis of hepatitis B virus, HBV, is based upon the presence of serological markers, antigens, and antibodies in plasma or serum. These include investigations related to hepatitis B, HB-Sag, HBeag, anti-HB, anti-HBs, anti-HB core, quantitative hepatitis B virus DNA, HBV genotype, for those considered for interferon, hepatitis delta virus, HDV serology, general liver investigations, FBC, bilirubin, liver enzymes, clotting, ferritin, lipid profile, autoantibody screen, ceruloplasmin, tests for hepatitis C virus, HCV, and HIV. Screening for liver cancer, ultrasonography, alpha-fetoprotein, surveillance testing for HCC in adults with chronic hepatitis B. Perform 6-monthly surveillance for HCC by hepatic ultrasound and alpha-fetoprotein testing in people with significant fibrosis or cirrhosis. In people without significant fibrosis or cirrhosis, consider 6-monthly surveillance for HCC if the person is older than 40 years and has a family history of HCC and HBV DNA greater than or equal to 20. Do not offer surveillance for HCC in people without significant fibrosis or cirrhosis who have HBV DNA less than 20,000 and are younger than 40 years. Staging of disease and secondary care. This includes transient elastography, which is non-invasive and has a high diagnostic accuracy for the detection of cirrhosis. Although the results may be confounded by severe inflammation associated with high alanine aminotransferase, ALT levels and the optimal cutoff of liver stiffness measurements varying among studies. Liver biopsy. This continues to play an important role in providing information on the etiology and severity of liver disease. Hepatitis B surface antigen, HB-Sag, indicates presence of viral envelope and suggests that the person is infectious. It rises during the incubation period and may be cleared early in the course of the disease. It is undetectable in around 10% of people by the time the test is performed. Chronic HBV infection is indicated by the persistence of serum HB-Sag for more than 6 months. Hepatitis B antigen, HBeag, detectable in the serum during both the early phases of acute infection and some chronic infections, usually associated with relatively high levels of virus replication. People with chronic HBV tend to be more infectious if HBeag is detected. If HBeag has been cleared, anti-HB is usually detected, and infectivity is lower. Antibody to HBeag anti-HB present following clearance of HBeag from the plasma. Disappearance of HBeag development of anti-HB, and a decline in HBV DNA indicate control of viral replication and predict resolution of acute hepatitis B. Antibody to core antigen HBcAg, anti-HBC, indicates current or previous HBV infection. Appears at the onset of symptoms in acute infection and persists for life. May be absent very early in acute infection. IgM antibody to hepatitis core antigen, anti-HBC, indicates recent, within the last 6 months, HBV infection. Quantification may be useful to distinguish between acute and chronic infection. It is usually replaced gradually by immunoglobulin G, EGD, anti-HBC. IgG antibody to hepatitis core antigen, anti-HBI, generally persists for life and is indicative of past infection. Antibody to HBsAg, anti-HBs, indicates recovery from and immunity to HBV. Anti-HBs without anti-HBC is a marker of immunization. Anti-HBs is quantified to measure vaccination response. Additional tests include quantification of HBV DNA, often referred to as HBV viral load, and HBV core avidity testing. High levels of HBV DNA are associated with a greater risk of progression to cirrhosis and hepatocellular cancer. Core avidity testing can differentiate between acute and chronic core IgM infection. Use clinical judgment to determine the required tests, depending on the suspected diagnosis. Initial testing should ideally be for at least HBsAg and anti-HBC. Positive HBsAg and positive anti-HBC IgM confirm an acute infection, particularly if supported by clinical suspicion and raised ALT. Positive HBsAg and anti-HBC, total or IgG, but negative anti-HBC IgM confirm a chronic infection. Different combinations of antibodies and antigens, alongside other findings, can indicate the phase of a chronic infection. Provide full clinical details to the laboratory to allow selection of the appropriate tests, including the person's vaccination status, whether the test is for past exposure or response to vaccination, whether or not acute hepatitis is suspected, whether the person is immunocompromised, when hepatitis B virus, HBV, DNA may be of more use. Note, the specific tests available may vary between laboratories. Table shows interpretation of serology tests for hepatitis B. You can pause the video to have a look at it. The differential diagnoses of hepatitis B include viral hepatitis caused by other viruses, such as hepatitis B, C, D, and E, Epstein-Barr virus, infectious mononucleosis, or cytomegalovirus, CMV. HIV. Hepatitis B is an HIV indicator condition. Non-alcoholic fatty liver disease. Alcohol-induced hepatitis. Suspect if there is a history of alcohol misuse. Drug-induced liver disease. Suspect if there is a history of paracetamol overdose or therapeutic use of paracetamol in a person who misuses alcohol. Autoimmune hepatitis. 90% of cases occur in women. Suspicion is raised by presence of other autoimmune disorders. Hepatitis caused by bacteria, such as leptospirosis and Coxiella burnetii. Granulomatous disorders. Metabolic and genetic disorders, such as Wilson's disease, hereditary hemochromatosis, alpha-1 antitrypsin deficiency. Prevention of infection with hepatitis B. General advice regarding hepatitis B to prevent infection. Patients should be advised to avoid unprotected sexual intercourse, including oral-anal and orogenital contact, until they have become non-infectious or their partners have received a full course of vaccination for protection against hepatitis B. Patients should be given a detailed explanation of their condition, with particular emphasis on the long-term implications for the health of themselves and their partner, and routes of transmission of infection, and should be advised not to donate blood. Hepatitis B immunization for people at high risk. Offer hepatitis B immunization to people at high risk of hepatitis B. Use clinical judgment based on the person's risk of already having been exposed to hepatitis B to determine the requirement for serology testing for immunity to hepatitis B at the same time as vaccination. People at high risk of previous exposure include babies born to mothers infected with hepatitis B, people with needle stick injury, sexual assault victims, injecting drug users, people who change sexual partners frequently, particularly men who have sex with men, and sex workers, close family contacts of a person with hepatitis B. For most people requiring pre- or post-exposure prophylaxis against hepatitis B, use a rapid immunization schedule given at 0, 1, and 2 months, or over 21 days if very rapid protection is needed, such as for needle stick injuries or imminent travel to a highly endemic area. For people where there is a high likelihood of compliance and rapid protection is not required, consider a 3-dose course of vaccine at 0, 1, and 6 months. If immunity to hepatitis B is demonstrated following initial serology testing, do not give the remaining doses of vaccine. Arrange for immunoglobulin prophylaxis to be given at the same time as vaccination for people without proven hepatitis B immunity. Following exposure to potentially infected blood or body fluids, including via needle stick, bite, or scratch injuries, contact with infected potentially material via mucous membranes, eyes or mouth, or broken skin, and unprotected sexual contact within last 7 days with a person with hepatitis B. If immunoglobulin prophylaxis is thought to be indicated, discuss this with a microbiologist at the local health protection unit before giving treatment. Hepatitis B immunoglobulin is given intramuscularly, ideally within 48 hours of exposure, and at the same time as the first dose of vaccine. The current recombinant vaccine is one of the safest available, but being grown in yeast cells, it should not be given to those allergic to yeast. Passive immunization with specific hepatitis B immunoglobulin, HBIG, may be given to non-immune contacts after high-risk exposure. Management of hepatitis B infection. Assessment. Arrange the following tests in primary care for adults who are HB side positive. IgA anti-HB status, HBV DNA level, LGM antibody to anti-HBC LGM, HCV antibody, anti-HCV, HDV antibody, anti-HDV, HIV antibody, anti-HIV, LGG antibody to hepatitis of virus, anti-HAV. Additional laboratory tests include ALT or aspartate aminotransferase, AST, gamma-glutamyl transferase, GGT, serum albumin, total bilirubin, total globulins, FBC, and prothrombin time. Tests for HCC, including hepatic ultrasound and alpha-fetoprotein testing. Referral. Refer all adults who are HB positive to a hepatologist or to a gastroenterologist or infectious disease specialist with an interest in hepatology. Refer pregnant women who are HB positive to a hepatologist or to a gastroenterologist or infectious disease specialist with an interest in hepatology for assessment within 6 weeks of receiving the screening test result and to allow treatment in the 3rd trimester. Refer immediately adults who develop decompensated liver disease. Refer all children and young people who are HB positive to a pediatric hepatologist or to a gastroenterologist or infectious disease specialist with an interest in hepatology. Adults with hepatitis B antigen positive chronic hepatitis B and compensated liver disease. Offer a 48-week course of peginterferon alpha-aminoase 2A as first-line treatment in adults with HB positive chronic hepatitis B and compensated liver disease. Offer tenofovir disoproxil as second-line treatment to people who do not undergo HB seroconversion or who relapse, revert to being HB positive following seroconversion after first-line treatment with peginterferon alpha-aminoase 2A. Offer entecavir as an alternative second-line treatment to people who cannot tolerate. Adults with hepatitis B antigen positive chronic hepatitis B and compensated liver disease. Offer a 48-week course of peginterferon alpha-2A as first-line treatment in adults with hepatitis B antigen positive chronic hepatitis B and compensated liver disease. Offer tenofovir disoproxil as second-line treatment to people who do not undergo hepatitis B antigen seroconversion or who relapse, revert to being hepatitis B antigen positive following seroconversion after. Line treatment with peginterferon alpha A. Offer entecavir as an alternative second-line treatment to people who cannot tolerate tenofovir disoproxil or if it is contraindicated. Avoid use of peginterferon alpha A in pregnancy unless the potential benefit outweighs risk. Women of childbearing potential must use effective contraception throughout therapy. Adults with hepatitis B antigen negative chronic hepatitis B and compensated liver disease. Offer a 48-week course of peginterferon alpha-aminase 2A as first-line treatment in adults with HB negative chronic hepatitis B and compensated liver disease. Offer entecavir or tenofovir disoproxil as second-line treatment to people with detectable HBV DNA after first-line treatment with peginterferon alpha-aminase 2A. Women who are pregnant or breastfeeding. Offer tenofovir disoproxil to women with HBV DNA greater than 107 in the third trimester to reduce the risk of transmission of HBV to the baby. Monitoring of adults who do not meet the criteria for antiviral treatment. Monitor ALT levels every 24 weeks in adults with hepatitis E antigen-positive disease who are in the immune-tolerant phase, defined by active viral replication and normal ALT levels, less than 30 in males and less than 19 in females. Monitor ALT every 12 weeks on at least 3 consecutive occasions if there is an increase in ALT levels. Monitor ALT and HBV DNA levels every 48 weeks in adults with inactive chronic hepatitis B infection, defined as hepatitis E antigen negative on 2 consecutive tests with normal ALT and HBV DNA less than 2,000. Consider monitoring more frequently in people with cirrhosis who have undetectable HBV DNA. Prophylactic treatment during immunosuppressive therapy. In people who are HB positive and have HBV DNA greater than 2,000, offer prophylaxis with entecavir or tenofovir disoproxil. Prophylaxis before beginning immunosuppressive therapy and continue for a minimum of 6 months after hepatitis B antigen seroconversion and HBV DNA is undetectable. In people who are HB positive and have HBV DNA less than 2,000, offer prophylaxis. Consider lamivudine if immunosuppressive therapy is expected to last for less than 6 months. Monitor HBV DNA monthly in people treated with lamivudine and change to tenofovir disoproxil if HBV DNA remains detectable after 3 months. Consider entecavir or tenofovir disoproxil if immunosuppressive therapy is expected to last for longer than 6 months. Start prophylaxis before beginning immunosuppressive therapy and continue for a minimum of 6 months after stopping immunosuppressive therapy. Hepatitis B in pregnancy. All babies born to infected mothers should receive a complete course of hepatitis B vaccine. Babies born to highly infectious mothers should receive HBIG, preferably given within 24 hours of delivery, as well as active immunization. HBIG may be given simultaneously with vaccine, but at a different site. This reduces vertical transmission by 90%.